Welcome to Clinical Capsule, your trusted guide for clear and concise medical learning.
There's arguably nothing more terrifying. Nothing that triggers that primal panic response faster than the feeling of not being able to breathe.
Oh, absolutely. It is a completely overwhelming feeling.
Right. Like when you are gasping for air, the entire world just shrinks down to that single desperate need.
Yeah.
You don't care about your job or your bills or whatever is for dinner. You just need oxygen.
Yeah, your brain just shuts everything else out.
So today, we have our hands on some really fascinating clinical notes detailing a highly structured approach to dyspnea. And our mission for this deep dive is to decode how medical professionals systematically handle this incredibly common and highly panic-inducing presentation.
Shortness of breath.
And we are bypassing the giant encyclopedia of 100 different respiratory diseases to go straight to the framework.
Yeah.
It's really a masterclass in problem-solving under pressure.
Okay, so let's unpack this. Dyspnea, which is the medical term for shortness of breath, is essentially a check engine light. It's a symptom, right?
Right. It's a purely subjective difficulty in breathing, not a diagnosis in itself. But if a patient is actively struggling to breathe and their check engine light is just flashing red, how does a clinician avoid, freezing up in the face of that palpable panic?
Well, that initial paralysis is the very first hurdle. And the answer is incredibly disciplined. It requires overriding your basic human instinct.
So what do they actually do?
You have to force yourself to pause all diagnostic thinking. What's fascinating here is the golden rule of triage, which is to assess severity first.
So you aren't trying to figure out the disease yet.
Exactly. The clinician is not trying to figure out if it's asthma or heart failure in that first minute. The fundamental law of emergency medicine dictates that airway, breathing, and circulation, the ABCs, always take precedence.
So if the patient's system is actively crashing, you stabilize them first and ask your diagnostic questions later.
That's it.
It's like you are checking if the engine is actively on fire before you try to plug in the diagnostic computer to read the error codes.
That is a great way to think about it. And there's a very specific, rapid, visual, and numerical checklist of emergency signs to look for.
The red flags.
Right, the undeniable red flags of respiratory distress. You start with the numbers, like, is their respiratory rate above 30 breaths per minute?
And a normal resting rate is what, somewhere between 12 and 20?
Yeah, usually. So if they are hitting 30 or more, their respiratory muscles are basically working at a sprint.
Wow, okay.
Then you look at oxygen saturation. Is it below 90%?
So that number tells you that despite the sprinting, despite all that mechanical effort, the actual gas exchange is failing.
Exactly. Oxygen is simply not making it into the bloodstream.
So the system is failing mathematically. But numbers only tell part of the story, right?
Mm-hmm.
There are distinct physical signs that telegraph this distress as well.
Oh, yeah. The physical signs are often way more alarming than the numbers. You look at their musculature. Like, are they using accessory muscles?
What does that mean exactly?
Well, normal, quiet breathing is driven almost entirely by the diaphragm, the large muscle at the bottom of the rib cage. It pulls down, creates a vacuum, and air rushes in.
Pretty effortless.
Right. But when someone is starving for air, the diaphragm isn't enough. The body recruits the accessory muscles in the neck and the shoulders to physically yank the rib cage upward.
Oh, to try and force the chest cavity to expand.
Exactly. It looks like they are physically heaving with every breath. You also look for cyanosis, a bluish tint to the skin, particularly around the lips or the fingertips.
Wait, why blue specifically? I know that's a classic sign, but what's the actual mechanism there?
It comes down to the color of hemoglobin. When hemoglobin in your blood binds to oxygen, it turns bright red.
Which gives healthy skin its pinkish undertone.
Right. But when hemoglobin drops its oxygen, it turns a dark purplish blue. So if a patient's lips are turning blue, it means an alarming amount of their blood is circulating without any oxygen attached to it.
That is terrifying. I've also noticed the notes heavily emphasize observing the patient's behavior, specifically altered consciousness, and whether they can speak in full sentences.
Yeah, those behavioral signs are incredibly ominous. Speaking requires controlling your exhalation.
So if they can't talk?
If a patient can only give you 1 or 2 words before needing to gasp for air, they literally cannot afford the physiological cost of a conversation. Every ounce of cellular energy is dedicated to ventilation.
And altered consciousness is even more severe, right?
Much more. If a patient becomes confused or aggressively agitated or unusually lethargic, it isn't just a psychological reaction to the panic, it is a metabolic crisis.
Their brain is shutting down.
Basically, yeah. Their brain tissue is actively starving for oxygen and it's beginning to malfunction.
So when a clinician registers these signs, the high respiratory rate, low oxygen, accessory muscle use, cyanosis, broken sentences, or confusion, the immediate priority is intervention.
Right away. You secure the airway, provide supplemental oxygen, and support their breathing mechanics.
Okay, so once that immediate crisis is managed and the patient is stabilized, the mystery is still entirely unsolved. You still have to figure out why the breathing failed in the first place.
Exactly, which requires categorizing the chaos. To avoid wildly guessing, clinicians use a rapid differential diagnosis.
Right, filtering the possibilities into 4 main physiological categories. And naturally, we start with the 2 most obvious anatomical suspects, the heart and the lungs.
Well, they sit right next to each other in the chest cavity, and they form the primary circuit of oxygen delivery. It makes total sense to start the investigation there.
But here's where it gets really interesting. I want to push back a little on separating these 2. Because the lungs bring the oxygen into the blood, and the heart pumps that oxygenated blood around the body. They're essentially a single, continuous delivery system. So if a patient is sitting on the edge of a bed struggling to breathe, how do you visually and clinically separate a pump failure from a bellows failure?
It is a brilliant question because their functions are so intertwined. The separation really comes down to understanding the mechanical fallout of each failure.
Okay, so let's look at the pump first.
Let's examine the cardiac causes. This includes conditions like heart failure, acute coronary syndrome, which is a heart attack valvular disease, and pericardial tamponade.
Got it.
When the heart is the root cause of dyspnea, the pump is failing to move blood forward efficiently. And in a closed circulatory system, when a pump fails, fluid backs up behind it.
Oh, so if the left side of the heart is failing, the blood waiting to enter the heart backs up into the lungs.
Exactly. The left ventricle is supposed to pump blood out to the body. If it gets weak, the blood backs up into the pulmonary veins, which are the pipes bringing blood from the lungs to the heart.
So the pressure just builds up.
Yeah, that increases the hydrostatic pressure inside the fragile blood vessels of the lungs. The pressure gets so high that fluid actually leaks out of the vessels and into the tiny air sacs, the alveoli.
Wow, so the patient is literally drowning in their own fluid.
They are. And that fluid shift creates very specific clinical clues.
The notes highlight orthopnea, which is shortness of breath that happens when the patient lies flat.
Gravity plays a massive role here. During the day, when the patient is standing or sitting, gravity pulls that excess fluid down into their legs.
Which is why swollen ankles are a classic sign of heart failure.
Right. But when they lie flat in bed at night, gravity is no longer keeping that fluid in their lower extremities. It all rushes back up into their core,
Flooding the heart.
overwhelming the already weakened heart and flooding those air sacs. That's orthopnea.
And that leads to a terrifying phenomenon called paroxysmal nocturnal dyspnea, right?
Yes, where the fluid accumulation causes the patient to suddenly wake up from a deep sleep, gasping for air, feeling like they are suffocating.
So swelling in the legs, waking up gasping, or needing to sleep propped up on, like 3 pillows. So all point to a fluid dynamics problem. It drops the symptoms squarely into the cardiac category.
Exactly.
You also mentioned pericardial tamponade. That sounds mechanical, not just like a weak pump.
Tamponade is a really terrifying mechanical failure. The heart sits inside a fibrous sac called the pericardium. That sac does not stretch very well.
So what happens if something goes wrong?
If trauma or illness causes blood or fluid to rapidly fill the space between the heart and that sac, it creates immense inward pressure. The heart is basically being crushed from the outside.
Oh, wow.
When the heart tries to relax and expand to fill with blood, it physically can't. It's pumping on empty. The patient struggles to breathe because there is virtually no blood circulating to pick up oxygen.
That paints an incredibly clear picture of the cardiac side. Fluid backing up with a pump being crushed. Now, how does that contrast with respiratory causes?
Well, respiratory issues are statistically the most common culprits. This includes things like asthma, COPD, pneumonia, pulmonary embolism, and pneumothorax.
So the clues here look distinctly different from the fluid overload clues of the heart.
Very different. Here, you are looking for evidence of inflammation, infection, or a physical obstruction within the airways themselves.
So we are looking for a cough, a wheeze, a fever, or pleuritic chest pain, which is that sharp stabbing pain that happens specifically when the patient takes a breath in.
Exactly. A fever strongly points to an infectious process like pneumonia, where the air sacs are filled with pus and inflammatory debris rather than clear heart failure fluid.
And a wheeze.
A wheeze indicates that the physical tubes, the bronchi, are narrowing. Air is being forced through a tightened space, creating a high-pitched whistle. That is classic for asthma or COPD.
What about the physical obstructions? Like pulmonary embolism is a blood clot, right?
Yeah, it's a blood clot that usually forms in the deep veins of the leg, breaks off, travels through the heart, and gets wedged in the arteries of the lungs.
So the air gets in, but the blood can't reach it.
Right. The lungs themselves might be inflating perfectly fine, bringing in plenty of oxygen, but the clot acts like a roadblock. Blood cannot reach those oxygenated air sacs.
So they are breathing, but it's not doing anything.
It's a massive mismatch between ventilation and perfusion. The patient is panting, but no oxygen transfer is happening.
And what about a pneumothorax?
A pneumothorax is a structural collapse. The lungs don't have muscles to inflate themselves. They are pulled open by negative pressure, a vacuum created between the lung and the chest wall.
So if there's a puncture.
If a blister on the lung pops, or if there is a puncture wound to the chest, air leaks into that vacuum space. The negative pressure is lost, and the lung simply collapses like a deflated balloon.
Man. The patient takes a breath, the chest expands, but the lung just stays collapsed.
Exactly.
Okay, so we've evaluated the pump and its fluid dynamics. We've evaluated the bellows, looking for obstructions or collapsed tissue.
Right.
But what if both the heart and the lungs are structurally sound? The mechanics are flawless, yet the patient is still sitting there hyperventilating.
This is where it requires a deeper level of medical detective work.
It's like having a perfectly fine car engine. No broken parts, no leaks, but it's running on the wrong kind of fuel. Or like a software glitch in the main computer is forcing the throttle wide open.
That analogy perfectly sets up the final two categories of our differential framework. These are the underlying culprits that can easily be missed in the chaos of an ER if the clinician is purely focused on the chest.
Category 3 is metabolic causes.
If we connect this to the bigger picture, this category is pure invisible physiology. The patient is breathing incredibly fast, but there is nothing functionally wrong with their respiratory system.
Wait, really? So why are they breathing so fast?
The lungs are merely the workhorses trying to fix a chemical emergency elsewhere in the body. They are hyperventilating to mathematically compensate for severe internal acidity.
Compensate how? I mean, if their kidneys are failing or they have a massive infection, how does breathing faster fix acid in the blood?
It all comes down to the body's acid-base buffer system. Carbon dioxide, when it's dissolved in blood, acts as an acid.
Oh, okay.
The body tightly regulates blood pH, and the brain has chemoreceptors that constantly monitor this acidity. Let's look at diabetic ketoacidosis, or DKA.
Right, a complication of diabetes.
Yeah. In severe uncontrolled diabetes, the body cannot use sugar for energy, so it starts rapidly burning fat. A byproduct of this fat breakdown is the production of ketones, which are highly acidic.
So the blood pH drops.
As these ketones flood the bloodstream, the blood's pH plummets dangerously.
The blood literally becomes too acidic to sustain normal cellular function.
Precisely. And the brain senses this lethal drop in pH and triggers a panic response. It knows that blowing off carbon dioxide will remove acid from the blood.
So it uses the lungs to fix the blood.
Right. It sends an overriding command to the lungs. Ventilate, blow off as much CO2 as possible immediately. The patient starts taking massive, deep, rapid breaths, a pattern known as Kussmaul breathing.
So lungs are essentially acting as a chemical exhaust vent to fix a problem caused by the pancreas.
That is exactly what is happening. The engine is racing, but the mechanics of the lung are totally clear. If you listen to their chest with a stethoscope, you won't hear the crackles of fluid or the wheeze of asthma.
The lungs sound perfectly healthy.
Completely healthy. The diagnostic clue is profound hyperventilation without any supporting chest findings. We see this compensatory drive in DKA, severe systemic infections like sepsis, or advanced renal failure.
Which brings us to the final category, other causes. This seems to be the catch-all for the remaining stealthy culprits. It includes anxiety or panic attacks, obesity, drug toxicity, and one that initially seems counterintuitive, anemia.
It does seem strange at first.
Yeah, I have to ask about this. A panic attack causes hyperventilation through the nervous system. Obesity places restrictive physical weight on the chest. But why would anemia, which is just having a low red blood cell count, cause someone to feel like they are suffocating?
It requires revisiting the core purpose of respiration. We breathe to deliver oxygen to our tissues. However, oxygen does not simply dissolve into the blood plasma and float freely to the brain and muscles.
It needs a ride.
It is a cargo that must be physically transported. That transport vehicle is a protein called hemoglobin, which lives inside red blood cells.
So red blood cells are essentially a fleet of delivery trucks.
Yes. If a patient is severely anemic, perhaps they have a slow, hidden bleed in their GI tract. Their fleet of trucks has been decimated.
So they can breathe in all the air they want.
Their heart might be pumping fiercely, and their lungs are inflating beautifully, pulling in massive amounts of oxygen. But when that oxygen crosses into the bloodstream, it finds an empty loading dock.
Wow. There are just not enough hemoglobin vehicles to carry the cargo to the tissues.
And the tissues are still starving for oxygen. They send a distress signal to the brain, and the brain's only solution is to demand faster breathing, even though more air won't solve a lack of transport vehicles.
The sensation of breathlessness is profound, and that is why the clinical framework establishes a hard rule. Always check hemoglobin.
Always.
If a clinician misses severe anemia, they might spend crucial hours ordering chest x-rays and echocardiograms, searching for a mechanical failure that simply does not exist.
All while the patient is quietly running out of oxygen transporters.
The logic of this structure is incredibly tight. We have our 4 diagnostic categories, cardiac, respiratory, metabolic, and other. But knowing the categories isn't enough. You need an efficient way to sort the patient's symptoms into the correct one while the clock is ticking. I mean, you can't just stare at them.
This brings us to the operational execution of the framework, the clinical history, and the physical examination.
Right.
Which raises an important question. What do you ask a patient when every single second matters and they can barely string 2 words together?
The framework suggests that a focused history provides the answer in the vast majority of cases.
And it distills the interrogation down to 3 vital questions. Question 1 is onset. How fast did this happen?
Because the velocity of the symptom reveals the underlying mechanics of the disease.
Exactly. If the onset was sudden, like if the patient was watching television 1 minute and gasping for life the next, you immediately suspect an acute mechanical event.
Like a pulmonary embolism or a pneumothorax.
Right, where a clot snaps off or a lung suddenly pops.
But if the onset is gradual, creeping up over days or weeks, it points to a chronic failure.
A gradual onset suggests wear and tear or a slow accumulation. It aligns with heart failure, where fluid slowly backs up into the lungs day by day, or the progressive worsening of COPD.
Then question 2 is position, which we touched on with orthopnea.
Right. If the shortness of breath gets significantly worse when they lie flat, the fluid dynamics point toward the heart.
But if it gets worse on exertion, like walking to the mailbox, it points to a broader cardiopulmonary inability to handle an increased oxygen demand.
And question 3 is associated symptoms. This is where you look for the company the dyspnea keeps.
Okay, so what else is happening?
Yeah, if they have a high fever alongside the breathlessness, an infection like pneumonia is highly probable. If they describe crushing chest pain radiating to their jaw, you must rule out a cardiac event.
And if they have a tight wheeze, you are treating an airway obstruction.
Those 3 parameters, onset, position, and associated symptoms, provide immense diagnostic clarity in less than a minute.
It's like playing an incredibly high-stakes game of Guess Who, where you only get 3 questions to eliminate the wrong suspects.
That's a great analogy.
Which leads to the physical exam. My favorite directive from the entire clinical approach is the instruction to look before touching.
It is a critical pause.
The discipline required to stand before a gasping patient, suppress the urge to immediately do something physical, and just observe for 10 seconds is remarkable.
Observation yields objective data that the chaos of the moment might otherwise obscure. The examination sequence is deeply standardized, starting with inspection.
So just looking at them.
You assess their respiratory effort, watch for that blue cyanosis, and critically, you evaluate the symmetry of their chest wall movement.
You are watching to see if both sides of the rib cage expand equally.
Right. If one side of the chest rises while the other barely moves, you instantly know you are dealing with a localized problem on the restricted side.
Like a massive pneumonia or a collapsed lung.
Exactly. Then the clinician moves to palpation and percussion. They are physically feeling the chest and tapping on it.
Palpation allows you to check for tracheal deviation, right?
Yes. The windpipe should run dead center down the neck. If it is visibly pushed to the left or right, it means something inside the chest cavity is building up enough force to shove the entire central anatomy to the opposite side.
like air trapped from a pneumothorax.
Right. Then you percuss.
Percussion is essentially medical echolocation.
It really is. It is utilizing sound waves to determine tissue density. By tapping firmly on the chest wall, you listen to the resonance of the space below.
And a healthy lung has a specific sound.
A healthy lung, filled with a mix of air and tissue, has a specific resonance sound. If you tap over an area and hear hyperresonance, a loud, hollow sound like striking a drum, it indicates an excess of trapped air.
Which is common in a pneumothorax.
Conversely, if you tap and hear a dull, flat thud like tapping on your thigh, it means the air has been replaced by something dense.
Like a pocket of fluid or a dense mass of infection from pneumonia.
It-
Finally, the clinician pulls out the stethoscope for auscultation. They listen to the breath sounds.
Auscultation provides the final puzzle pieces. The framework highlights 3 critical auditory clues.
Okay, what are they?
If you hear crackles, a sound similar to rubbing strands of hair together next to your ear, it points to pulmonary edema. You are literally hearing the tiny air sacs popping open through a layer of heart failure fluid.
Oh, wow. And wheezing.
If you hear a wheeze, the air is whistling as it is forced through inflamed, narrowed bronchioles, indicating asthma or COPD.
And what if you listen and hear breath sounds? Just complete silence over a section of the lung.
Then no air is moving through that tissue at all. It heavily supports the diagnosis of a collapsed lung or a massive fluid effusion blocking the lung from expanding.
So what does this all mean? When we zoom out and view this clinical capsule in its entirety, it synthesizes the core philosophy of emergency medicine beautifully.
It really does.
Dyspnea, despite being inherently terrifying, does not have to be chaotic when approached systematically. You do not need to memorize a massive textbook of obscure ailments to save a life.
No, you don't.
The key to confident clinical practice is relying on physiological principles. Assess the severity immediately to ensure the patient's system isn't crashing. Categorize the potential failures into those 4 logical groups.
The cardiac pump, the respiratory bellows, metabolic compensation, and the hidden culprits like anemia.
Extract rapid clues with a focused history of onset, position, and associated symptoms. Perform a targeted, disciplined examination, remembering to look before you touch. And only then do you confirm your deductions with lab tests and imaging.
The elegance of the framework is matched only by a profound philosophical point buried in the introduction of the notes.
Oh.
Yeah, the text explicitly defines dyspnea as a subjective difficulty in breathing. It is entirely defined by the patient's own internal perception of distress.
Right, it's the sensation of suffocation, not just the physical act of it.
Which raises an incredibly important question for you, the listener, to think about. If the defining symptom of this medical emergency is entirely subjective, it highlights the inherent fragility of human communication during a crisis.
That's a powerful thought.
A patient might be too panicked, too exhausted, or simply unable to articulate exactly what is feeling inside them.
Is that vulnerability, that reliance on a subjective feeling, the very reason why the objective clinical signs, the measurable respiratory rate, the visible cyanosis, the dull thud of percussion are so utterly vital?
Exactly.
Because when a patient's words fail, their physiology will still tell the truth, provided the clinician has the discipline to read it.
Provided they have the discipline, yes.
That is a brilliant thought to end on. We want to thank you for joining us on this exploration of the medical mind.
We really hope this breakdown gave you a deeper understanding of the physiology behind every breath.
And an appreciation for the structured art of clinical problem solving. Keep asking questions, and we will catch you on the next deep dive.